I'm Adora, and this is my econ honors thesis called Gatekeeping Medicine, Unpacking the Cost of Applying to Med School. And I do just want to thank my advisor, Dr. Koskinen, for helping me throughout this whole very long process. All right, so there is currently a physician shortage in the United States, especially in the field of primary care. But along with that, there has been an increase in the competition for actually getting into medical school. According to the AAMC, or the Association of American Medical College, the average GPA and MCAT scores for matriculating med students have consistently risen. Back in 2001, the averages were about 3.6 and 508 out of 528. And then 20 years later, in 2021, that rose to about 3.74 and about 512 out of 528, increases of about 4 and 1% respectively. Alongside that, there has also been an increased requirement for more and more involvement in extracurricular activities. Because of that, gap years are becoming increasingly common just to give students a way to accommodate time to fulfill all these requirements. Now, what do these requirements actually entail? Like I mentioned, maintaining a high GPA and scoring high on the MCAT are both super important. In addition to that, physician shadowing, which is unpaid, and participating in clinical hours and activities are both important to kind of understand if the medical field is a good fit. In addition, there's a community service or volunteering requirement, which is unpaid, and that can look like a lot of different things, clinical or non-clinical. And then lastly, there has also been an increased focus on research. That can look like wet lab, clinical, computational, lots of different things, but that is often unpaid. And overall, all these activities are super time-consuming and potentially very expensive. So the costliness of this application cycle as a whole really got me thinking about how that kind of self-selects the people that end up becoming doctors. I think that becoming a physician should be a path that anyone can aspire towards, but if all aspects of the application cycle depend so heavily on income, then that can't really be the case. So my ultimate research question, which was what can quantifying those barriers in the United States reveal about socioeconomic diversity among physicians, and then what are the impacts on primary care as a whole and patient health outcomes? So I wanted to include this diagram quickly just to familiarize you all with the medical education pipeline to primary care. Now this is a rough estimation showing how that volume flow works out. If we start with pre-med students, that is including anyone who enters college initially declaring pre-med. So out of all of them, only about 17% actually complete the required coursework to apply to medical school. So that looks like Gen Chem, Orgo, classes like that. Out of those students, about 40% matriculate into med school. The rest were either discouraged by those barrier costs or switched for another reason. Most of the matriculants do graduate from med school, about 95%, and then about 40% of them go on to a primary care residency. Now, only about 20% of those residents actually end up practicing outpatient primary care because the rest either become hospitalists or subspecialize in a different field. Now, the overall point of this diagram is really to show that addressing that barriers problem does have these downstream effects on that supply of physicians. So let's get into the fun part, the actual cost. This is the first half of my cost table showing a lot of the direct costs to the applicants. That looks like MCAT registration fee, MCAT prep materials, CASPER exam fee, and primary and secondary applications. So these things have that direct upfront cost, but they also have a very significant time commitment associated. So that is shown in the third column there. Because of that time commitment, there's something called opportunity cost in econ, which is basically that the time students spend doing these activities, they could have spent earning an income. So in the two columns on the right, I calculated that using a low $9.21 hourly wage, which is the average national minimum wage, and then also a $35 hourly wage, which was cited as the average salary for pre-meds. So that kind of gets a low and a high estimate there. Now this is the other half of the exact same cost table, but showing more of the extracurriculars. Now those don't have those direct upfront costs associated, but they do have very significant time commitments. So in the third column there is the recommended hours from a consulting company called Med School Coach, which basically tries to help pre-meds build a competitive med school application. So looking at the bottom row there, you can see that the total cost, and that's per applicant, is just over $37,000, and the total hours is just under 1,300. Now, I think that's a pretty jarring number even on its own, but it's also really interesting to see how that's changing. So this graph is showing how the cost of applying to medical school coincides with increased deterrence from applying. So basically what I did here is I repeated that same cost table, but researched how the values would differ in 2016 and 2020. That is plotted in the red. And then I combined that with survey data from the AAMC in the yellow, and that is showing the percentage of applicants that felt deterred from applying due to the costs associated with applying. So you can see that the increased deterrence due to application costs is really coinciding with those increasing barrier costs. Now, moving further, I also wanted to take a look at matriculating med students. So this is the familial income distribution brackets over 3 years from 2022 to 2024. And you can see an interesting trend from the arrows among the low and middle income brackets. They are all downward sloping, so they have been decreasing in representation, whereas among the high income brackets, they are upward sloping, so those have been rising in representation. Using that same AAMC data set, I wanted to take a look at how those students funded their pre-medical education. So this graph spans more years, back from 2019, and you can see the sources of funding are generally pretty stable or even slightly decreasing. Interestingly, the money from scholarships and awards, which is in yellow at the top, and then directly under that in orange, the money from parental guardian support, both make up the two most significant percentages of funding. Now, there's three main reasons why this research really matters, and I would summarize those as being a lack of socioeconomic diversity among physicians, a low supply of primary care physicians, and suboptimal patient health outcomes. So physician shortages are just worsened by these high financial barriers because they're discouraging qualified students from applying, and they're also reducing socioeconomic diversity among the physician workforce. Now, barriers are really just supposed to be identifying who is a qualified applicant, but if they're also discouraging even qualified students from applying just because they happen to come from underserved backgrounds, then there's obviously an issue there. Now, diversity has a lot of profound impacts on patient well-being, and there are lots and lots of studies that show that patients have more trust and satisfaction when they're treated by physicians from similar ethnic, language, and racial backgrounds. They've also found that patients are more likely to comply with medical advice and even visit their doctor more often when these things are reflected in their physician. Studies have also found that physicians from underserved communities were more likely to practice primary care and were also more likely to serve those underserved communities themselves. Overall, increasing the socioeconomic diversity of med school matriculants would therefore help to improve healthcare equity in this way while also advancing preventative medicine. Now, overall, I hope this has at least a little bit helped illuminate how increasingly long, expensive, and competitive the med school application cycle has become, especially in recent years. Trying to take an economic approach to this issue and quantifying these financial barriers kind of reveals how systematic and financial factors are really shaping who becomes a doctor and who doesn't. So this really underscores the need for some policy changes, which I did not directly evaluate in my paper, but could look like things like subsidizing application costs, rethinking the weight of the MCAT, reducing the weight of unpaid extracurricular activities, and things like that, just to help open doors for more students. Now, the crux of this all is that med school admissions committees really need to be focused on identifying which variables will predict the success of all applicants and not just the ones from high SES backgrounds. And this isn't just an issue of fairness. Really, it's about taking steps towards helping alleviate that physician shortage, better serve underserved communities, and even just building a more equitable healthcare system that really reflects the needs of a diverse U.S. population. Thank you. Any questions?
Great job, Adora.
Thank you.
Is there a trend to look at this and start doing about actually doing something about it for students?
Yeah, so I go a little bit more into this in my paper, but for example, the AAMC actually uses this holistic review model now, which is actually kind of aimed at looking more into the socioeconomic background of applicants and also their healthcare experiences. And so research into that is limited as to whether that increases diversity or not. But the effect of that is that it can unintentionally put more weight on those extracurricular time requiring activities, which are also costly. So there are definitely moves to try and alleviate this, but they're not necessarily super successful.
All right, great job, Adora.